muscarinic inhaler on formulary currently is Breva HandiHaler. And as you see, that's the hardest one to do. Oh, my notes are out of order. So phase 2 has taken a lot longer to get out there, and that has to do with the inpatient side. So we just started this in June, so we're just at the infancy of it. And from the get-go, we knew navigating the inpatient admissions was going to be the most challenging to find the patients we should give education to. So we actually worked with UC Davis, who created a similar EPIC report that what we're using. And this is kind of confusing to explain because it's confusing for us to use at times, and we have to kind of go with our gut. So basically, the report queries admissions based on a primary diagnosis or hospital problem list of COPD, bronchitis, shortness of breath, pneumonia, asthma, what's some others? Thank you. And the reason why we query both primary diagnosis and hospital problem list is in our system, that primary diagnosis is based on when they first came to the door, here's what the physician thought they had. But as we know, as they're there longer, they start thinking, okay, maybe it's not this. But that's not updated in real time. So we had to really go by the hospital problem list as well. And then it brings in, obviously, the patient information, such as location, MRN, age. We had them bring in whether they are on oxygen, bronchodilators, steroids, and antibiotics. So if a patient has COPD exacerbation as a primary diagnosis or it's on their hospital problem list, they automatically make our list and we'll go do education for them. If a patient has COPD on their hospital problem list but isn't necessarily being treated for exacerbation, that's when they must meet like 3 of 5 criteria, which are age over 40, scheduled bronchodilators, oxygen order, steroid order, or the antibiotic order. And this is a way to help us triage so we can put the ones that are clearly the more higher risk for readmission. And if they don't have 3 of those 5 criteria, but they still do have COPD, then they're kind of, depending how busy we are, we still try to reach those patients as well. But they're kind of lower on the totem pole, I guess. We run this report each morning, Monday through Friday, so the educators can identify these new admissions of patients they will provide education to. And our COPD educators are 3 of our diagnostic staff, and we have 1 inpatient respiratory therapist who's an educator. All of them have completed the COPD educator training, as well as pulmonary disease educator, or pulmonary disease educator training, or asthma education. The goal is to do 3 to 4 sessions, so each day we're wanting to come back and do more. And then throughout this time, they're obviously collaborating with the multidisciplinary team, trying to share some of those things that they are wanting to recommend and get orders for. And then we also created a database that we're collecting data on these patients that we're seeing so we can evaluate what we need to do with the program in the future. So kind of our workflow is actually, after we've run the report and identified the patients that we should be seeing, we do a patient checklist, which just collects basic data, and that's kind of for that database later on. We do kind of a medical record review, which helps us get more background information. And we have patient education folders that have just some handouts for them, and they're the basic ones because we have all kinds of handouts, but instead of packing that folder full of everything we have and throwing it at them, we wait until after we see the patient to see what their goals are or what they might need extra help with, and then put those things in there so it's really tailored to them. The therapists do an educational assessment because, as Danette talked about, it's very important to know what your patient's ability is to learn and tailor to their needs. it's also important to know what their goals are and what they're willing to do. Then we start doing these educational assessments and start going over inhalers, breathing techniques, different things like that. So some of the tools we use is we created a tabletop display flip book. And this book can be utilized in the education sessions. And basically it has a patient side that has some pictorials and short messages or instructions. But then on the flip side that the therapists see, it goes into detail and puts down some commonly asked questions or key messages. And this helps us create a streamlined standard message so patients aren't hearing different things from various therapists. We want it to be consistent. And the book is divided in several sections. The section 1 is just an overview on COPD and how breathing works. The next one goes more into detailed information about the medication. What's a rescue inhaler? What's a maintenance inhaler? When do you take what and how? And then we use the inhaler education toolkit, obviously, to start doing those demonstrations with them. Section 3 is more about triggers that increase symptoms and the best way to avoid them, as well as a little bit about smoking cessation. We don't push it. Patients have to be ready to do it. When they express interest, then we start talking about it more. And the last section is all about self-management strategies, controlled cough technique, huff coughing, pursed lip breathing. And you'd be surprised how many COPD patients do not know what pursed lip breathing is. They haven't been taught. And to me, that was like RT-101. I remember learning that right away. Even breathing techniques for walking, stair climbing, lifting, and carrying. And we collaborated with Pulmonary Rehab on this because we wanted even a consistent message with what they were saying. So some of their slides we just stole from them, so we are all on the same page. And they're actually wanting to use this book now because it incorporates some of the stuff they didn't have handouts on. And one of the more important things that we're doing is creating an action plan. And the patients have really enjoyed having these because it basically has on one sheet of paper the patient's contact information, what their doctor's phone number is, who their resource person is, like who do I call in an emergency. And then it breaks down like, here's what I do when I'm feeling like this. Here's what I do when I'm feeling worse and like this. That way patients stop and think, I shouldn't just go to the ER. Maybe we can, okay, when you're first starting to feel this, take your rescue inhaler, see how that's doing, and then escalate the more your symptoms get worse. So throughout this process, the educators are gathering information from the patients, the medical record, and they're deciding if other assessments are warranted. Like, did their home inhaler routine seem appropriate? Can they adequately use that particular inhaler device? So they're using that in-check dial to make sure that what they're prescribed in-house and at home, they're getting the medication. Do they have a questionable COPD diagnosis? Again, if there's no PFTs or any other evidence, they're calling up the physicians and asking for it. We've had a lot of success with that, but we've also had resistance. And I guess the only thing we can do at that point is just keep going back at them and being more detailed on why it's important to get those tests. If they've complained of being short of breath when walking, maybe we should do a walking DSAT study. Maybe they need to be on oxygen. Have they complained of extreme fatigue and problems sleeping? Well, then we do a stop-bang sleep apnea assessment to score them, like maybe we should be recommending a sleep study. Maybe they actually have some underlying sleep apnea. And we're deciding if pulmonary rehab would be appropriate. We're also making sure our moderate to severe COPD patients are getting follow-up care with pulmonologists. In particular, we have an obstructive pulmonary disease clinic, So we're trying to get them referred over there so there's a better transition of care. We work with the physicians, social work. Sometimes we've had therapists contact the DME themselves instead of waiting for social work to do it because they're overwhelmed with all the work they've got. So we're just trying to basically ensure patients are transitioned post-discharge as smooth as possible. So whatever we can do, we're trying to do it and address it. So our next steps are, one, we're going to create our own instructional videos for inhaler and breathing techniques that will be available on the inpatient Tiger on Demand channel. There's tons of videos on YouTube, but our hospital likes to have a lot of committees. So we can't just post a YouTube video or a manufacturer video. They have to go through this committee and get approved in this committee. That takes time. So what I found out is if we make our own, we avoid committees and we can do it. So that's the route we're doing. And we've also recruited pulmonary fellows to help us with it because patients, even though I don't know why, patients seem to listen to what doctors say more. The problem is doctors aren't really talking to them very much. So we are recruiting them to help us with that. Pharmacy is now evaluating different inhalers to include more inhalers on their formulary because they've recognized through this work that we've done that, Spiriva is not a really good one to have on formulary. We have no other options. And they also run into a lot of patients are on completely different medications at home, but when they come in, they have to switch to something else because we don't have it. So then you're teaching them yet another device to learn, and then when they go home, they have to remember how to use what they were on, and that's confusing. So hopefully we do get more of these inhalers added to our formulary. We are working on creating that COPD exacerbation admission order set that will have evidence-based practice built into it, so then the physicians don't even have to think about it. Have PFTs are checked, pulmonary rehab check, respiratory education check. What am I forgetting? That I think maybe those are the main ones. Yes, thank you. We are also working to implement a respiratory therapy-driven bronchodilator protocol for COPD exacerbation patients. And this basically would allow RT to determine when that transition from short-acting to long-acting happened, and based on their assessment, what type of inhaler they actually should be on. Can they actually do the specific ones that we have available? And it will allow us just to put that order in and bypass the physician altogether. So basically, if they ordered that protocol, all the work after that is on us. And it's a specific algorithm that would follow. And lastly, we're wanting to expand to include other diseases such as asthma. So some lessons we've learned throughout this project is definitely network, because other facilities have done a lot of work and don't try to reinvent the wheel. Our program that we've come up with is actually little tidbits from various programs. No, you're going to have to make improvements along the way and changes. We've changed a lot since we started, because once you get into it, you learn more. You can't anticipate everything, and you have to be willing to adapt. And most importantly, you have to choose the right people to do this work. You have to have people that are dedicated, passionate, and willing to go through the rough spots and stay with it. Because if you don't have the right people doing this that are truly engaged and believe in it, it's not going to be successful. So with that, I would like to recognize Wendy Heppel, Tony Cooling, Shanna Overstreet, and Crystal Fedoris for doing an amazing job. They're our COPD educators. And I would also like to acknowledge Frances Kramer, because she's helped us with all of the admin stuff, and she built that database, which was frightening, because database is not good. And so she has provided a lot of support in this whole project. And I would like you ladies to meet me out front, because I have something for you. So with that, any questions? Yes. So some of us took the COPD educator and or pulmonary disease educator through ARC. And then others of us actually, the American Lung Association in Minnesota does a COPD educator 2 days course, and it is phenomenal. I recommend anybody to go to that. You get so much more information out of that than doing the online program.